Thank you very much. I hope you're refreshed with a nice cup of coffee. And we're going to get started with session 2. It's my great pleasure to introduce the first speaker, Dr. Robert SIDONIO, Jr., who's joining us today. He's a graduate from the University of Alabama Medical School, completed pediatric residency at the University of Louisville and his fellowship at University of Pittsburgh, where he also obtained a master's degree in clinical investigation. He's been the Associate Director of Hemostasis and Thrombosis at Emory since 2014, and he has a clinical and research interest in investigating the bleeding phenotype and genotype of women with hemophilia, carriage, and low von Willebrand's, funded by the Hemophilia of Georgia Clinical Scientist Development Grant. In addition, he has pilot studies focusing on quality of life and menstrual bleeding treatment in hemophilial carriers and women with low von Willebrand's. Welcome, Dr. SIDONIO.
All right. So thank you very much for inviting me to come here. What a great location. The weather is fantastic. It's actually warmer than it is in Atlanta, which is hard to believe. But thank you for inviting us. So I'm going to talk a little bit about bleeding in carriers. And I always just put everything on every slide just so there's complete transparency. But I don't think there's any obvious conflicts of interest that would, when discussing this study, because I'm not going to talk about my pilot studies. So I know you guys saw the data from Winikoff where she showed what was going on in Canada. We'll talk about what's going on down south. And so in the Athens data set, which is the American Thrombosis and Hemostasis Network, is the surveillance system that we're collecting data in the United States. And it's sort of taken over for what the CDC is doing. And then there's also a supplement called CDC Community Counts. So the most recent data cut that I had, and we have a paper coming out by Christina Haley and myself, you can see the numbers of women. These are females with bleeding disorders. And so you can see that there's obviously a large number of women with von Willebrand disease, but in the United States, we should have significantly more than 4,600. The qualitative platelet disorders is, definitely another talk. You can see that the hemophilia A carrier, the numbers have risen significantly. So since the CDC universal data collection, it was closer to 200 to 300, and now it's pushing close to 600 the last time we looked. And this was a lot driven by the My Life Our Future free DNA testing project, which really pushed us to enroll patients in the study. And I'm just going to go through this very briefly. As expected, when you look at the breakdown, the vast majority have mild deficiency. And there actually are quite a number of women that have normal levels, which I think is important to include, and a smaller number that have severe and moderate disease, and we have a few at our center with Turner syndrome. And then on the B side, it's pretty similar, smaller numbers as expected, but the vast majority have mild deficiency. And so when I first got started on this project, I'm sure a lot of people had the same sort of issue back in about 2012. I actually got a lot of pushback from a lot of physicians about how silly this research was. So I think it's really important, and I applaud people that have pushed forward, and I also make sure people understand how far we've come in just the last 5 to 10 years. But we did a simple electronic survey where we sent out the same survey to CDC docs and nurses, and we sent the same one out to women from a patient advocacy group called Hemophilia Federation of America. And I just wanted to capture at the moment, what do people think about bleeding? And so about half of the providers thought that carriers with normal levels have an increased bleeding tendency. I'm hoping that at some point we'll repeat the survey and see if any of the stuff that we're doing and what you're doing here made a difference. But there was an obvious discrepancy with the carriers strongly believing that there was an increased bleeding tendency. And most of the providers at the time preferred deferring any genetic testing till later, which made sense. If you don't think that they bleed, why would you do genetic testing earlier? And I know that's a different topic, but most of the carriers preferred earlier testing because of that bleeding tendency. And so, when you go back in the literature, even before PubMed, the first study that I could find was actually from the 1950s, really small study, 19 patients. They reported increased oozing from dental extractions in hemophilia carriers. It wasn't quite clear. I think most of them were obligate carriers. And there was a little bit of commentary from the article in 1986 about the contribution of blood type O affecting carriers. Most of the study was focused on hemophilia, and particularly males with hemophilia. But it showed that there was issues with variations when they looked at factor VIII sent across the world. They got pretty radically different results as expected. And so this was obviously the biggest paper. There was a commentary afterwards. So this was a postal survey that was done in Europe. And I think it captures pretty well what we think. And so there was a wide range, as you can see, levels of as low as 5% and as high as 219%. They combined hemophilia A and B, which some of us would say maybe we shouldn't. And they also did some comparison of people with the same levels, whether they were carriers or not. So there are some limitations on this. But it really was, and I apologize, I guess it shifted a little bit. But in patients, when we're discussing small wounds, there was a higher risk, 2.2 times higher risk of bleeding with small wounds. There was a higher risk for bleeding with dental extractions and requiring treatment after intervention, and more likely to have prolonged bleeding afterwards. I apologize for the shift. So I think we all get it. If somebody's levels are lower in the 20% range, women, they should bleed, right? That's not something is a big deal or something major. I think the most interesting thing was the fact that people in this sort of borderline range, sort of the same issues we deal with low VWF, that they were at increased risk of bleeding. So this is sort of what got me interested in this field. And so we did this cross-sectional study, a case control study while I was at Vanderbilt, and we decided that we would do a small study, but we actually did extensive testing on all of the patients, controls and carriers. We did full thrombophilia evaluation. We did all of the hemostatic evaluation, including platelet eggs. We wanted to get a pure group of women, and we actually chose the controls were mothers of children with cancer because we felt as a control group it wasn't fair to ask somebody on the street that has no idea about bleeding, doesn't understand any of those nuance. And oftentimes we were criticized saying, well, the mothers that are hemophilia carriers, they're just more educated about bleeding, so they're more likely to report it. So we wanted to get past some of these many concerns that everybody would verbally tell us at many meetings. And so we only had to eliminate one patient with factor V Leiden. But as you can see, anywhere where there's an asterisk, there was an increased bleeding tendency or statistical difference between the green bars, which was the carriers, and then the controls in the red bars. And so some of it didn't reach statistical significance. But I think I think it's really important to note that we did a full workup on these women, but there were heavy menstrual bleeding is a common problem, and I think that's where it gets often mixed up because it's a common problem throughout, and I'll show you a little bit more data on that. And so when you look at other symptoms, and these are questions pulled from the MCMD, I think it's number 4 back from the bleeding scores. I think it's halfway through the arrow that Paula showed. But bleeding events that were concerning, having to change a pad every 1 to 2 hours, or having to use birth control for heavy menstrual bleeding. So all those were significant. But you can see some of them didn't reach significance in our studies, but was fairly close. And so when you quantified it using that questionnaire at the time, that's the one that we chose, we saw that there was a significant difference whether you looked at individual bleeding symptoms or not. And remember that we only had one patient with a level below 45% on this study. So this was the average hemophilia A carrier. We only chose carriers because it was a smaller center. We didn't have a lot of hemophilia B patients. And as I reminded Paula, I presented this data back at the SSC years ago, and I didn't know that she had similar data, and she presented right before me. And so I was out in the audience sweating, thinking that she was going to show something different. And so if you look, if you look here, the pictorial bleeding assessment chart, which was alluded before, there was a significant difference, and anybody who's taking care of these women, their periods are quite heavy. And as you can see here, the threshold, even though it's as high as 150, that was pretty common in normal women. We did a full evaluation, so we know none of those women had any bleeding disorders. But it's common in the normal population, and I think that often gets confused. This is not my study. This was a study done in Europe by Dr. Olson, and in hemophilia B carriers, much larger control group, but a much smaller number of hemophilia B carriers just because of the rarity of it. And she got fairly similar results, maybe a little bit less prevalent, but showed similar results that there was increased postpartum bleeding, heavy menstrual bleeding, nosebleeds, and bleeds with minor wounds. So one of the questions that's come up over the decades is, how do we predict the phenotype? We have not been able to do predicted at all, and it's really hard to publish a negative study, so we've been holding off on publishing this. But using sort of an arbitrary bleeding score, so I think this is important because they sort of created a bleeding score system to evaluate it. But what they were trying to get at is they were trying to say that patients that have null mutations or mutations that were commonly associated with moderate and severe disease, they were more likely to have bleeding. We have not seen that in any of our studies. They showed that here, but we have not been able to replicate that. And so that's something to consider, but I'm not sure that that actually is a real finding. And then another thing that was interesting is there was this thought that there's a difference in levels based on the mutation type. So people thinking if you had a severe mutation, you were more likely to have a lower factor level. And that just hasn't shaken out in any of the studies that we do, and I'll show you a few other ones. So this was one in hemophilia B. You can see here, interesting enough, we don't see this in hemophilia A, but in general, once the level goes above 75%, you're significantly less likely to be a hemophilia B carrier. So sort of like the poor man's test if you don't have the ability to do genotyping. But if you look here, how you split it out by the mutation type, the levels really didn't make a difference. There's just nothing there. So the mutation doesn't predict the actual residual factor levels in hemophilia A or hemophilia B. And again, additional studies showed the same thing in this case control study. There was no correlation between the phenotype and the level. And again, this is one of those things that makes it very frustrating and difficult, and I think this has led to some of the marginalization and some of the poor communication between providers and carriers. And again, they showed the similar bleeding score. One of the things I think is interesting and maybe sort of relevant to what Paula was discussing about the sister study, this was a nice study. So this was done in an Amish population near Amy Shapiro. They have a single mutation as expected, large number of women that are affected by it and men. And what was really fascinating is that there were 64 women in this study. The median age was 18. The bleeding scores were as low as 0 and as high as 8. And as expected, the level is about 45%, but there's a wide range. And most of us would joke that in this population, they probably share a lot of other similar DNA. You would have expected that most of the women carrying this single mutation throughout this community and tending to marry within this community would have all about the same levels, but it's just radically different. And we didn't really find a correlation in bleeding symptoms, but most of the patients had scores in this range of about 3 to 4. And so, again, this just says there's something out there that we don't understand. Lionization, there's got to be something else. And, we're just discussing about mosaicism as a potential contributor. And so one of these things that always comes up is about joint bleeds. Probably the most controversial topic that comes up about hemophilia carriers and probably the most emails I get from patients. And so we decided we wanted to get this issue. So the CDC has been collecting joint range of motion in males with hemophilia for quite a long time. It was quite interesting. When I went on their website, I looked and noticed they actually had women on the site. I thought maybe it was a mistake, and I called the CDC and asked them about it. And they said, oh, yeah, well, some sites felt like the women had the issues, and so they just put them in. So actually, sites had to go in and write their name. They had to write in hemophilia A or B carrier under other. And we actually had to eliminate quite a number of patients because they just put hemophilia carrier, and there was no way for us to know. But they used the same physical therapists, the same physicians. And so initially they told me that they didn't think the data was very good, but it was the same people at the centers collecting the same data for the males. And what we saw was the CDC did a normal study of women and show, as expected, over time, your range of motion goes down. And we had to normalize this because you had to include all of the joints that were involved. But what was interesting, when you took the hemophilia A and B carriers, it was statistically reduced range of motion compared to normal women. So we compared by age, and we eliminated severe obesity because of the issues with joint range of motion. And so we saw a difference between, it wasn't a huge difference, but there was a difference. And as expected, you kind of get a dose response. As the factor levels go down, you expect to see the range of motion to get worse. That's not surprising. This part was a little bit funny because unfortunately a lot of these patients also had passed away from HIV and hepatitis, so we didn't have a lot of patients in their 40s and 50s. And so we wanted to look at this. We did a simple study. We enrolled 9 patients. One of the patients got pregnant, so we didn't do the study. It always bothers me we only have 9 instead of 10. My OCD it just bothers me every time I see this slide. And so, so this bleeding score is here. We have the BMI here. And, as I know Manny points out at so many sessions, our BMI tends to be higher than maybe in the Canadian population. But you can see here only 2 of the women actually reported joint bleeds. And so we took patients that had reduced range of motion in their ankles and knees, and we decided to get MRIs. MRIs are quite expensive. If you ever had to do a study, it's about $1,000 an hour, and it takes an hour to do one joint. And so we saw actually data that was similar that you would see in a mild deficiency patient. We saw abnormalities in, particularly in the ankles and knees. It's very difficult to do elbows and hips. We report the data, but it was quite difficult to do because we just didn't have the setup for that. And we actually captured, I don't have it on here, but the other patient that actually had fluid in the joint, and this patient actually had hemosiderin deposition. And we had external radiologists review this because when we submitted to Hemophilia, they didn't believe it, and I had to get additional people to validate this because they thought it would be quite controversial when we published this. And so, I know they're going to talk about this more, so I'm not going to spend a lot of time just for time, but postpartum hemorrhage rates, I think we have to get a better understanding of what those bleeding rates are. If you talk to a lot of GYNs, they feel like how aggressive the GYN is will determine how bad your postpartum hemorrhage rates. And if you look at these, they use different definitions, which makes it a little bit difficult. But it probably is slightly higher. And the problem is that you saw the variation in patients. We obviously need to, once we get more numbers, we can sort of separate patients out by mild deficiency, normal levels, and then obviously defining what's normal for a woman. And so I'll finish up on this thing, this last couple of slides. And so one of the things that we've always sort of heard is that what are the carriers like? People want a reference point, right? And so they say, well, they bleed like a von Willebrand patient. And so we wanted to look at this. We haven't published this data. We're still one of the students. I got to get to finish this up. But we took patients that were enrolled in the female universal data collection project. So right before the CDC stopped collecting that data, they got together, spent a couple of years putting this group together, collected data, and then of course it ended. And so, but they did collect data on women, and so we wanted to publish this. And so this is the breakdown. It's overwhelmingly a Caucasian, most women in their 20s. And so these were women that had levels less than 30% and were labeled locally as type 1, whatever that means. Back then, I'm sure there's some that didn't have type 1. And then we wanted to compare it to the women that had factor VIII or IX deficiency. Again, similar age group. We wanted to compare to the patients that had normal and mild deficiency because you thought that was a good comparison. I think trying to add the severe and moderate doesn't make sense. And so if you can see here in the group, and these are the bleeding, this is basically all that was collected, and so I'm just sort of at the mercy of what was collected. How do they bleed? And so, the rates of mucosal bleeding were much higher in these type 1 patients compared to the ones with deficiency. So you see a statistical difference, higher rates of nosebleeds, higher rates of minor wounds, higher rates of heavy menstrual bleeding, but you could say that's a pretty high number in general as well. And then iron deficiency, at least self-reported, was higher in these women as expected. Interesting to me is that you saw similar rates of joint bleeding, similar rates of muscular bleeding, and then bruising rates, which is quite subjective, obviously. You saw similar rates. And so, I think at some point, hopefully we'll be able to figure out where the phenotype is, and maybe that'll help some of our providers understand some of the bleeding. And so I'll leave it on this slide, and I think I used this slide at FVIII. Someone made a comment that I was trying to compare women to cats, and so that's not what I'm trying to do. So these are the calico cats. And so this is actually a visual representation of X-linked inactivation, right? And so it's quite interesting that you can see this visually, and I always wish you could see that sort of in a woman. And I would get people to read this article from the New York Times, which actually challenges a lot what we know about mutations and how there's some significant differences from organ to organ. And there's an interesting case of a young child in which they were not able to find the mutation from standard DNA testing, but actually found the mutation in the heart tissue after he had a heart transplant. And so I think some of the answer may lie in that, and some of the answer may lie in some of the work that Paul and I are doing with Tori, looking at stress response and DDAVP response. I personally feel that the variability, particularly on the milder end, has to do with the ability to mobilize von Willebrand factor and sustain it. And I really think that, or factor VIII, sorry, not von Willebrand factor. I really think that would explain some of the variability, and that's what makes it a little muddy. And everyone here probably knows that patients that have a great ddAVP response, and then we have carriers that have levels of 40% and it doesn't go up more than 5%. And so for me, I would think that patient would be at risk for bleeding because they're not able to mount the response that they should mount. And so, hopefully, I know there's going to be a debate later, and so I'll be interested to see how everybody feels about that. So thank you very much for allowing me to come today and talk about that, and I'm happy to discuss anything afterwards.
I think we have time for one question.
I'm Julia. I'm a physiotherapist in Calgary.
Yes.
I was just wondering, the MRI that you showed with the hemosiderin deposition, was that in a carrier with normal levels or with low levels?
That was one with normal levels.
Okay.
And so, and there's actually, I get a lot of comment when I'm doing posters, somebody will come by and say, oh, I run a lot, so my joints probably look like that. But there's a nice study in which they did MRIs of athletes from college, like competitive athletes, and they don't get hemosiderin deposition in their joints, unless they had a tear of some sort. And so that notion that people have hemosiderin deposition and that looks the same is really just kind of a silly one. So thank you.